All right, I think we'll go ahead and get started with pediatric grand rounds today. All right. Today's presenter is Dr. Okoye. She's a PG-3 in pediatrics. She earned her undergraduate degree from the prestigious University of Notre Dame in Notre Dame, Indiana, and earned her master's degree in healthcare and human services administration from St. Mary's University of Minnesota. While obtaining her master's degree, she gained experience working as a business analyst as one of the top healthcare institutions in Minnesota and as a revenue analyst at the 7th largest pediatric health systems in the United States. She later earned her medical degree from Indiana University School of Medicine in Indianapolis. After graduation, she plans on pursuing outpatient and healthcare administration opportunities out of state. Please join me in welcoming Dr. Ogochukwu Okoye, and her faculty advisor was Dr. Alan Blackwood. Thank you.
Thank you, Dr. Parmeshwar. Good morning, everybody. My name is Ogochukwu Okoye. And as you can tell from the title of my presentation, we're going to be talking about autoimmune disease, particularly rheumatologic complaints in the pediatric population and JIA. All right, and so this is our roadmap for the presentation this morning. We'll discuss the presentation and management of macrophage activation syndrome, or MAS, in a pediatric patient with systemic JIA, also known as SJIA. Summarize the clinical findings and labs that differentiate the different categories of juvenile idiopathic arthritis, or JIA. Identify the clinical and lab findings in SJIA. Talk about the management of SJIA, and then the complications that are associated with systemic JIA. All right, so we'll start our discussion off with the case. So just to kind of give you a time frame, I'm seeing this patient. I was on a 24-hour shift. I get a call from the ED right before midnight. We have an 11-year-old female who has a past medical history of systemic JIA that was diagnosed in 2018. She comes in complaining of several weeks of fever and intermittent joint pain. Next. Back pain. Next. And the joint pain began 3 weeks prior to presentation. It's intermittent in nature. There were some days where she had no fever, she had no symptoms. However, 10 days prior to presentation, she had a fever of 102 every evening until she presented to us. And the fever is associated with bilateral arthralgia. All right, so about 48 hours prior to admission, she develops a non-peripheral rash on her face and her extremities. Next. Rash is most prominent when she has no URI, no GI, traveled anywhere recently, nobody at home or at school is sick. And prior to presenting to us, just a few days earlier, on the 29th of April, she came to the ED complaining of similar symptoms. She got a workup that was negative, and she was subsequently discharged, and it was suspected that she had a flare of her systemic JIA. And some other she was born full term, vaginal. Only complication was just a nuchal cord. Otherwise, it was a normal delivery. And as mentioned, she has this diagnosis of systemic JIA that was diagnosed back in January. She does have a family history of autoimmune disease. She has a maternal great aunt with lupus. Her dad has Crohn's disease. Paternal grandmother has arthritis, and she has 2 older brothers, both of whom are healthy. And as far as medications, the only medication she's on is anakinra, trade name Kineret. She takes 80 milligrams once a day for immunosuppressant therapy for JIA. And Dad was saying that she has not missed any doses. She also takes naproxen as needed. She lives with Dad, no pets at home, and parents are divorced. So I'm going to backtrack to when she presented back. And so she comes to the ED, Peds is consulted. When she came in, she was complaining of several days of fever, chills, headache, sore throat, ear pain, knee pain. The knee pain is intermittent. She describes it as being similar to her typical SJIA pain, and it improves every night when she takes anakinra. As far as her headaches, there's no associated nighttime awakenings from the headache. The headaches are not worse in the morning. There's no vomiting, no sensitivity to light or vision changes when she has the headaches. So at the time that Peds was consulted, her symptoms had resolved after she got a dose of ibuprofen in the ED. So no headache, no knee pain or ear pain when Peds saw her in the ED. So As far as her vitals, she was febrile on the ED, had associated tachycardia, but that tachycardia improved after she got ibuprofen. Her, as far as vitals, blood pressure was 100/59, tachy to 132. She was febrile to 101.6, tachypnic with a respiratory rate of 26, and she was sat 95%. Her physical exam was normal. Her neuro exam was normal as well. So as far as the lab work that the ED obtained during that time, it was significant for leukopenia with a white count of 3.8 and a mild thrombocytopenia with platelets of 128. Elevated inflammatory markers, CRP was 1.42, ESR was elevated to 29. She had a mild metabolic acidosis, bicarb of 19. She had a transaminitis, AST of 250, ALT of 227. They also obtained monospot, respiratory viral panel, rapid strep, and eventually the throat culture, or obtained a throat culture, and that was all those were negative as well. They obtained a urine that was a clean catch specimen. It was positive for leukocyte esterase, occasional bacteria, and 10 to 25 white blood cells. So after PEDS saw recommendations, next. So the first was to follow up on blood culture and the COVID test. So the other labs that the ED obtained was a blood culture and swabbed her for COVID. And the blood culture finalized no growth at 6 days, and her COVID test was negative. Because of that questionable urinalysis, they sent for a urine culture, and the urine culture next. PEDS recommended a non-hepatitis panel, and EBV titers both were negative. And she was advised to continue her ibuprofen and naproxen for headaches, fever, and joint pain. And as we do with every patient, pediatric patient that comes into the ED, I advise her to follow up with a pediatrician in 1 to 2 days and to repeat the LFTs in about 1 to 2 weeks. And also the other recommendation was to talk to her rheumatologist regarding a possible flare exacerbation of her systemic JIA. All right, so fast forward now back to when I see her in the ED. So her physical exam, as far as her vitals, blood pressure 121/61. She's febrile to 102.9. Breathing comfortably with a respiratory rate of 18, tachycardic to 138, 98% on room air, and her weight was 54 kilograms. So just general, she's well appearing, she's conversing, does not look like she's in any distress. On her HENT exam, only thing was just a mild erythema of her lips, clear oropharynx, otherwise the rest of it was normal. Normal cardiac and lung exams. Because she was complaining of that back pain on the exam of her back, she had mild tenderness to palpation along the lumbar spine, but there was no point tenderness. Neurologically, normal neural exam, she's able to ambulate, jump in place, no difficulty or pain, normal mental status. As far as her musculoskeletal exam, she has full range of motion, no deformities to any of her joints. There's no swelling or erythema. And as far as her skin, remember, she was complaining of that skin rash, or had that skin rash. So she had a faint erythematous maculopapular rash on both cheeks, diffuse erythematous macular rash on bilateral upper and lower extremities, and there were some similar lesions on her back as well. The rash does blanch when you press on it, so it's not petechial. So she had a very extensive workup in the ED. She was found to be pancytopenic. She had a white count of 2.7, ANC of 1800, ALC of 600, hemoglobin 10.2, and platelets of 98. CMP was significant for a mildly low albumin and calcium, a slight elevation in her AST 132 and ALT of 86. C3 was normal. So she was found to be hyperferritinemic. Ferritin level was almost 4,000, around 3879. Next. CRP was elevated. Next. ESR was normal. Next. And we obtained urinalysis, quite negative. Culture was pending at that time, and her urine protein was 30. And if you, when she was here back when she had presented on the 29th of April, there was no proteins in her urine. And these lab abnormalities are bolded because they'll be important later on when we talk about the complications of SJIA. And they obtained a rheumatoid factor, which was negative. Double-stranded DNA was also negative. So the ED team called her rheumatologist at VCU, and the rheumatologist recommended additional labs. And they thought that given her unremarkable complement factors, C3 being normal, C4 being mildly elevated. It didn't think a flare was the underlying cause of her signs, symptoms, and some of her laboratory abnormalities. So we admitted her for ongoing evaluation and management. So upon admission, I talked to ID, explained, told them the story that she had been here 4 days earlier, swabbed for COVID, bounced back with a high fever again. So they didn't think it was unreasonable to swab her for COVID again. So we got another COVID test, and that was negative. We obtained a respiratory viral panel, parvovirus, IgG, and IgM antibodies, and all these were negative. So because until the COVID test returned back, we just went ahead and put her on contact and droplet precautions, just precautionary. And then we continued her on her anakinra 80 milligrams daily. So it's non-hospital day 1. The team, I handed the baton off to the team. So now next day they're talking to the rheumatologist, and he made recommendations. So they wanted a repeat CBC and ferritin, triglycerides, coags, peripheral blood smear, LDH, haptoglobin, and blood culture. And along with the recommendations, the rheumatologist said if her CBC and ferritin were starting to look concerning for worsening macrophage activation syndrome, then she would need to be started on pulse dose IV steroids. And then having a low threshold to transfer her to VCU if she needed to be closer to her rheumatologist. So the results of the labs that were obtained, repeat CBC, she's still pancytopenic. Now her white count has worsened, dropped to 2.1. Platelets are now at 99,000 and hemoglobin of 10.2. So we went ahead, started her on the IV methylprednisolone. She was maxed out at 1,000 milligrams daily. Repeat ferritin showed that it was trending down. Remember, it was close to 4,000. Now it's about 3,000. CRP was starting to downtrend as well. We're now at 3.9, and LDH was elevated to 961. Fibrinogen was normal. Triglycerides were elevated. The blood culture eventually resulted, it was no growth. Haptoglobin was normal. The coags were normal as well. And the urine culture came back, final read, 40,000 colony-forming units, mixed urogenital flora. So this was likely a contaminant. Remember, that was a clean count. Day 2, she's continued on the pulse dose IV methylpred. Her rheumatologist recommended that she start methotrexate sub-Q 25 milligrams, and she's supposed to get this every 7 days, so once a week. Repeat CBC, white count has now improved from 2.1 to 2.6. ANC is at 900, absolute lymphocyte count 800, but her anemia worsened a little bit, dropped down to 9.7, and the thrombocytopenia was starting to improve a little bit. Liver enzymes were also improving. AST is now at 87, ALT at 73. And we obtained a repeat CRP, ferritin. Those were downtrending. CRP was now at 3.10, and ferritin was now at 2262. Remained normal. LDH was starting to come down from 961. We're now at 728. Oh, and triglycerides went down to 147. So it's now day 3. She is continued on the pulse dose IV methylprednisolone. So now this is the 3rd day that she has received consecutive IV methylpred with 1,000 milligrams. Her white count is now normal at 4.6. ANC rebounded to 3,500. ALC is at 700. She was still anemic, a hemoglobin of 9.1, but now platelets are normal at 148. Ferritin was still elevated, but it was starting to downtrend. We're now at 1176. As far as her hepatic function panel, AST was improving. It was still mildly elevated at 58, and ALT was on the high end of normal at 60. And throughout her admission, her fibrinogen remained normal. So she's discharged on day 3, fever and her symptoms. Next, the labs were trending in a positive direction. There's no clinical laboratory findings to suggest that the MAS was worsening. And this is just a recap of all the medication changes that happened with her rheumatologist while she was here. So rheumatologist recommended that her dose of anakinra be increased from 80 to 100 milligrams daily. She was discharged with prednisone 60 milligrams daily, and then also put on famotidine for GI prophylaxis while she was on the steroids. And as I mentioned, started on that weekly subcutaneous methotrexate. So now that we've talked about that patient's case, we'll just talk about juvenile idiopathic arthritis, or JIA. So JIA, formerly known as juvenile chronic arthritis, juvenile rheumatoid arthritis, JRA, or Still's disease. So it's a chronic arthritis, 6 or more weeks of arthritis. There's no known cause, and it presents in children before the age of 16. Next. As far as etiology, it's believed to be multifactorial. There's very few practicing rheumatologists in the United States, so the burden lies on pediatricians, family medicine doctors, emergency medicine physicians as the front line to identify and treat JIA. So the worldwide incidence and prevalence is not really known. It's believed that it varies. As far as in the United States, estimated incidence is 14 for every 100,000 children. And as far as prevalence, it's 113 per 100,000. So how do you diagnose JIA? So with everything else in medicine, most of your information is going to come from the history and the physical. It's a clinical diagnosis. There's no lab test that will differentiate JIA from any other disease. So as you're taking the history, listen for things like morning stiffness or achiness for at least 15 minutes in the morning. So in a toddler, look for a grumpy or limping toddler in the morning or after they take their afternoon nap. They may say something about the stiffness or the pain that improves with activity or as the day progresses. And it could also complain of joint stiffness if they've been sitting for a long time after a long car ride. And they could also talk about swollen or decreased range of motion of their joints. So in the exam room, there's some things, a lot of your physical exam can be done just by observing the child. So look at how the patient positions their extremities, how are they getting on and off the exam table. Look at them when they're walking or running, have them run down the hallway and see how they're coordinating their limbs. Are they limping or favoring one limb over the other? When you examine the joints, look at all the joints, looking for signs of arthritis. This would be swelling, warmth, restricted range of motion, or tenderness with range of motion. And look for signs of chronic arthritis. This would be muscle weakness or atrophy secondary to them not using that limb. Look for bony overgrowth. Bony overgrowth, you would see this as leg length discrepancy. So the leg that is affected will be longer due to overgrowth. And if they're complaining of jaw pain, if they're presented with TMJ arthritis, you can look at their jaw, they could have microarthropathy. There are other things you can look at outside of the joints, the extra-articular features. So this would be look for enthesitis, which is inflammation of the entheses. And entheses, this is the sites where tendon and ligaments insert into bone. This can be seen in several categories. Okay, next, something that you can do while you're doing your physical. And some of the common locations to look for enthesitis would be the Achilles tendon around the knees, particularly at the 10, 2, and the 6 o'clock positions, the greater trochanter, metatarsal heads, and the plantar fascia insertion on the foot. Another extra-articular feature would be psoriasis. Look at the nail beds, look for pitting of the nails, and this would lead you to a diagnosis of psoriatic arthritis. So this is just a picture showing a child with arthritis. The left knee with the red arrow is showing you that the inflammation in that joint. And then the black arrows are pointing out the positions on the knee where to look for enthesitis, the 10, 2, and the 6 o'clock positions. Continuing on with the extra-articular features, uveitis can be seen in several categories of JIA. Look for synechiae. So this is abnormal or distorted pupillary shape due to uveitis. And this would be a clue to a long-standing uveitis, the synechiae. This requires immediate referral to an ophthalmologist who will do a slit lamp exam and then treat the patient. And the concern here is that since the uveitis in JIA is asymptomatic, once it is identified, then these patients need to be seen an ophthalmologist to preserve their vision and prevent blindness. And the current AAP guidelines state that children with JIA need to have regular screening by the ophthalmologist to check for uveitis. The differential diagnosis for JIA is very broad. So, patient comes in complaining of joint pain, warmth, erythema. There are other things that it could be besides arthritis. So bacterial and joint infections. So if you're thinking septic arthritis, osteomyelitis, you would see kids with this all the time, viral post-infectious arthritis like reactive arthritis, rheumatic fever. There are other autoimmune diseases that can present with joint pain. IBD, we've had several patients on the floor with Crohn, ulcerative colitis. Kawasaki can do this as well, lupus, mixed connective tissue disease, Beckett syndrome, sarcoidosis. And of course, you always want to rule out malignancy. So leukemia, lymphoma definitely can present with joint pain. And then malaria, the interesting with malaria next is that it presents with that same fever pattern that you would see in systemic JIA, joint pain, evidence of systemic illness. So when you're asking patients about this, screen them. Have they traveled recently to any endemic areas in the world? If they are, then you're going to obtain a thick blood smear to exclude the diagnosis of malaria. Continuing on with the differential, there can be endocrine conditions like thyroid disease that can have joint pain as well, or similar symptoms to JIA. Heme-wise, sickle cell, thalassemia can have similar presentations. Some other heritable diseases like mucopolysaccharidosis, Marfan, Ehlers-Danlos syndrome. And then some immunodeficiency syndromes like combined variable immunodeficiency and DeGeorge. And then there's some miscellaneous that don't fit into any of these other categories, like toxic synovitis of the hip, serum sickness, and hypertrophic osteoarthropathy. So how do you work up JIA? So there's no lab test that is diagnostic of JIA. So when you're obtaining these labs, it's really to exclude all these other things on this long list of differential. So patient comes in, they have a swollen, painful joint. It's warm, they kind of look toxic, systemic symptoms, fever, malaise. Go ahead, tap the joint. You're assess the synovial fluid to rule out septic arthritis. If you're suspecting, if you're on your differential, an indolent infection like Lyme or TB. If you're suspecting Lyme, obtain ELISA with confirmatory Western blot. TB, interferon gamma release assay is the gold standard. And to rule out malignancy, get a CBC with differential, blood smear, CRP, inflammatory markers, CRP and ESR. And keep in mind that if your ESR and CRP are normal, that doesn't exclude a diagnosis of JIA because these inflammatory markers can be normal in localized disease, such as oligoarthritis. You can obtain an ANA. ANA is not useful because 40 to 50% of patients with JIA can be ANA negative. ANA, the utility of ANA is to risk stratify for uveitis. If patients with JIA have positive ANA, then they're at greater risk for uveitis. And as I mentioned before, these patients need to be sent to ophthalmology to get to be screened on a regular basis. So you can obtain a rheumatoid factor. It's non-specific. It's not really reliable for diagnosing JIA because about 10%, only 10% of children with JIA will have a positive rheumatoid. There's some imaging that can be obtained, namely point-of-care ultrasound. MRI can identify active synovitis. So MRI can show you early joint damage, such as joint space narrowing or erosions. But what the imaging can't tell you is the reason why the patient has the arthritis. So underlying infection, malignancy, inflammatory, that goes back to your history and your physical. So how do you treat JIA? You want to treat it rapidly and aggressively, and the goal is to control the inflammation. Once remission is achieved, then you gradually taper. And the treatment goal is pain, getting the patient back to their baseline function and range of movement of all their joints. Of course, remission, and then making sure that there's a few side effects to any medications that you put them on. So this is just a table that's showing the different biologics that can be used for JIA. The thing that's interesting is that for JIA, we'll talk about systemic JIA management later, but just for JIA, these medications like etanercept, adalimumab, infliximab, these are actually FDA approved for certain ages in JIA. And then there's some off-label uses as well. And it also shows the mechanism of action. And there's a reference, it's a Pediatric in Review article where this table was obtained. So as far as classifying JIA, the classification was done by the International League of Associations for Rheumatics. They categorize JIA into 7 mutually exclusive categories, and it's based on several things: the number of joints that are involved, any extra-articular features, and serology that's identified in the first 6 months of disease presentation. So we'll look at the 7 categories. The first one is systemic JIA. That's what our patient presented with, so that's what we'll. You've got polyarticular JIA rheumatoid factor negative, polyarticular JIA rheumatoid factor positive, oligoarthritis, enthesitis-related arthropathy, psoriatic arthritis, and undifferentiated. So systemic JIA. Diagnostic criteria includes arthritis that lasts for at least 6 weeks and fever that's present for greater than or equal to 2 weeks. And this part is important. You have to document a quotidian or daily fever for 3 or more days during that 2-week period, plus 1 or more of the following: an evanescent or transient erythematous rash, generalized lymphadenopathy, hepatosplenomegaly. Next. So when you're working up systemic JIA, you want to make sure that you do a workup to evaluate for any infectious or malignant causes for the fever. Blood culture, blood. Next, serology, imaging, and or bone marrow examination. 1/3 of patients over systemic JIA, 1/3 of patients will either present with macrophage activation syndrome at their diagnosis, or they will develop it later on. So what is macrophage activation syndrome, or MAS? It's a life-threatening complication of systemic JIA. It is a medical emergency. It's a secondary form of hemophagocytic lymphohistiocytosis, or HLH. MAS is characterized by a rapid expansion of macrophages and T cells. So just think of it as like just an out of control cytokine storm. It leads to massive overproduction of cytokines. Next. So there's a long list of features that we're going to list out here. Some of them are bolded because we'll talk about those later. But persistent fevers, bleeding diathesis, some of these kids can come in with a hemorrhaging, CNS involvement with drowsiness or seizures. CNS involvement is actually a late finding of macrophage activation syndrome. They can have fixed rashes, cytopenia, which our patient was pancytopenic. Fibrinogen will be low, D-dimer will be elevated, triglycerides will be elevated, abnormal liver enzymes, which we saw with our patient as well, and hyperferritinemic. So greater than 5,000 is what is not unusual. Sometimes ferritin levels can be as high as the tens of thousands. So 50,000, 80,000 is not unusual in MAS. And of course, hemophagocytosis, you can see this in the bone marrow lymph. So talk about the pathophysiology of MAS, and this will explain why the laboratory abnormalities are seen in MAS. So hemophagocytosis will lead to anemia, thrombocytopenia, and leukemia. So the T cells activate the macrophages. The macrophages start to consume your platelets, your white blood cells, and your red blood cells, hence leading to anemia, thrombocytopenia, and leukopenia. There's an infiltration of the histiocytes and lymphocytes into the liver, and this will lead to the transaminitis that you see. The hypercytokinemia, an active production of ferritin by the macrophages, is what causes that marked elevation in the ferritin level. Decreased lipoprotein lipase activity, which is initiated by TNF alpha, will lead to the high triglycerides. And increased plasminogen activator secreted by the macrophages results in the conversion of plasminogen to plasmin, and this is why the fibrinogen level is low. And the low fibrinogen leads to the ESR decreasing. So since MAS is a secondary form of HLH, to discuss HLH, what is it? So it's excessive inflammation and tissue destruction is due to an abnormal immune activation. So natural killer cells and or the cytotoxic lymphocytes are unable to eliminate the activated macrophage, so they're just eating up all the cell lines. And it results in excessive CD8 T cell and macrophage activation. You'll get a high level of interferon gamma and other cytokines that the cytokine storm. So this picture was obtained from UpToDate. This is just showing reactive hemophagocytosis. This is a red pulp of the spleen. So that the blue arrows are showing the large lymphoma cells, and the black arrow is pointing to erythrophagocytosis. So it engulfs red blood cells. And this is a patient who has macrophage activation syndrome triggered by Epstein-Barr virus infection. This is a bone marrow. The red arrows are pointing to the phagocytosed nucleated red blood cells, and the black arrows are pointing to the phagocytosed platelets. Continuing on, so it's a patient will present acute, subacute febrile illness, multiple organ will be involved. Diagnostic criteria: fever, splenomegaly, bicytopenia, triglycerides will be elevated, low fibrinogen level, you'll see hemophagocytosis. And the thing that differentiates the HLH from MAS, if you look at the ferritin levels here are low, so they're around 500, lower absent natural killer cell activity, and the soluble CD5 levels would be elevated. And so there are two types of HLH. There's a primary type or familial HLH, which is an inherited disease. And then there's a secondary HLH, which is triggered by other diseases, including infection, malignancy, autoimmune disease. So don't think of HLH and MAS as two separate things. Like it's just MAS is a form of HLH. So some of the pitfalls with trying to use the diagnostic criteria of HLH for MAS. So maybe it's because HLH, you see it in the adult population, it's extensively studied. But they have criteria for diagnosing HLH. That the same is not true for MAS. So physicians are still using the HLH criteria, but it's not really suitable for patients with an underlying autoimmune disease, especially systemic JIA. The fibrinogen levels are elevated, a little bit more elevated in systemic JIA than you would see in HLH. Remember, it's like around 2, it's around 2.5, so it'll be around 2 for MAS, and the cutoff level for HLH is less than or equal to 1.5. So using that criteria may not help you get to the diagnosis of MAS. And also, as I mentioned, the ferritin level in HLH is greater than 500, but in MAS, we see it as 5,000 into the tens of thousands. Checking the NK, natural killer cell activity, and the soluble CD5 levels, that might not be readily available in the pediatric population or where you are, but it's something that they can check in the adult. But relying on this criteria to diagnose MAS may delay diagnosis, or you may miss. Next. So what's a physician to do? If you can't rely on the diagnostic criteria for HLH, then what can you look for? So one of the things that you can look for is look at the fever pattern. So when the fever changes from an intermittent nature to non-remitting, that's a clue that the patient could be going into MAS. So remember, with our patient, she presented 3 weeks prior. So symptoms started 3 weeks prior to presentation. There were some days where she was afebrile, some days where she was asymptomatic, but then 10 days before presentation, she had a fever every day for 10 days. So she went from intermittent to non-remitting. Look for fever-related cytopenia. She came in febrile and she was pancytopenic. Hepatosplenomegaly and lymphadenopathy are other important clues. So the study by Kostick et al., and they saw that these clinical features had a high sensitivity but poor specificity, so you can still use it as a screening tool. Other studies have shown that recognizing clinical symptoms, the subtle changes in laboratory, and importantly, monitoring the changes are crucial for diagnosing MAS. So there's some laboratory values, the platelet count, AST, ALT, ferritin, LDH, triglyceride, and D-dimer levels that will have a greater than 50% change from the time the patient presents when they're pre-MAS to when they are full onset MAS. So the other challenge is, how do you tell MAS apart from a systemic JIA flare? So if you see a relative decrease in the platelet count, that's the most valuable indication that will differentiate MAS from a systemic JIA flare, because systemic JIA characterized by leukocytosis and thrombocytosis. So when the patient has this relative dip in their platelets, that's a clue that they're heading into MAS. Also Kostick et al., their study showed that there's several laboratory values that will be listed below. So they found that greater than 3 of the following labs were a reliable indicator for early diagnosis of MAS. So decreased platelets and white blood cells, decreased albumin and fibrinogen, increased ferritin, increased AST, increased LDH, and the presence of proteinuria. So if you recall, when our patient first came in on no protein in her urine. The second time when she came in, when she was pancytopenic, there was presence of proteinuria. And they found that these indications provided the highest sensitivity and specificity for diagnosing MAS-associated systemic JIA early. So how do you manage systemic JIA and MAS? So systemic JIA, mild disease, you can start off with and go into corticosteroids if you need to, methotrexate. Methotrexate has been better for arthritis than the systemic features of fever or rash. And then, of course, you have the biologics. And the anti-interleukin 1 and anti-interleukin 6 agents were preferred. So MAS, you treat aggressively. IV pulse, methylprednisolone. Usually it's 30 mg per kg per day to a max of 1,000 milligrams for 1 to 3 days consecutively. Our patient was maxed out at 1,000 for 3 days. High dose anakinra is another option, or you can add cyclosporin, or just add so it's high dose anakinra and cyclosporin or cyclosporin. So again, this table from Peds in Review, this is specific for systemic JIA. And the thing that I noted here that was interesting, so these were not even approved for, FDA approved for systemic JIA, but they're used off-label, and they seem to work because our patient was anakinra, and this is used for off-label for systemic JIA and systemic JIA with macrophage activation syndrome. So now that we talked about systemic JIA, you know how to recognize it, you know how to treat it. Let's talk about the rest of the categories of JIA. So there's polyarticular JIA, rheumatoid factor negative, and polyarticular JIA, rheumatoid factor positive. Diagnostic criteria include arthritis, greater than or equal to 5 joints in the first 6 months of disease, and they're RF negative. Same thing for polyarticular JIA, rheumatoid factor positive, same diagnostic criteria. However, rheumatoid factor will be positive. But the thing with RF is that you have to obtain it twice, 3 months apart. And the reason is because patient could also have an infection, the rheumatoid factor level. So obtaining it the second time will confirm the presence of rheumatoid factor if there was an acute infection. So this is just a picture showing polyarticular arthritis. So if you look, it seems for this patient, I'm assuming it's a girl, there's nail polish. If there's just the thumbs and maybe the right fourth digit are the only digits not involved. But if you look at the PIP joints, almost all the fingers are. Next category, oligoarticular JIA. So this is the most common category of JIA. Diagnosis includes involvement of 4 or fewer joints in the first 6 months of disease. And there are 2 subtypes. Persistent oligoarticular JIA affecting no more than 4 joints, and then extended oligoarticular JIA affecting a total of greater than 4 joints in the first 6 months of disease. So the phenotype for OJIA, usually not always, see it in a 2 to 4 year old patient. They're coming in with a limp, swollen of lower extremity joints. Usually the knees are involved. The labs will be normal. CBC with differential inflammatory markers will be normal. And in 70%, about 70% of patients with OJIA have positive. There's good long-term prognosis. Then for psoriatic JIA, diagnosis includes presence of arthritis and psoriasis, or arthritis plus. Next. Dactylitis or sausage digits. Next. Relative. Next category, enthesitis-related arthritis. Diagnosis is made by the presence of arthritis and enthesitis, or arthritis or enthesitis plus. Next, sacroiliac joint tenderness or inflammatory lumbosacral pain, positive HLA-B27. The onset of arthritis in a male child older than 6 years of age, acute anterior uveitis, history of ankylosing spondylitis, history of enthesitis-related arthritis or sacroiliitis, and family history, inflammatory bowel disease, reactive arthritis, or acute anterior uveitis in a first-degree relative. Next. And the last category is undifferentiated JIA. So this is JIA that does not meet any of the criteria of these six we already talked about, or they have signs and symptoms that they can fall into 2 or more of the other categories. Next. Okay. All right. So now that you can recognize systemic JIA early, how to treat it, and then be able to recognize the other 6 categories of JIA and the approach, how to work these patients up, I have a few Mlc board questions for you. So the first one, you have a 13-year-old girl comes to your office complaining of joint pain for several months. Mom says that she has difficulty getting out of bed in the morning due to stiffness. She denies any fevers, weight loss, change in appetite, visual problems, or rashes. Physical exam, remarkable for multiple small and large joint swelling and painful range of movement bilaterally. Rest of the exam is unremarkable. The anti-CCP, antibody, rheumatoid factor, and anti-nuclear antibody tests are still pending. So which of the following is true regarding her disease? She has enthesitis-related arthropathy. She's likely to have a negative ANA, RF, and anti-CCP tests. B, she has oligoarticular juvenile idiopathic arthritis. If the ANA, RF, and anti-CCP tests are negative, she will likely have more aggressive disease. She has psoriatic juvenile idiopathic arthritis. She's likely to have a negative ANA, RF, and anti-CCP tests. D, she has systemic juvenile idiopathic arthritis. Her ANA, RF, and anti-CCP tests will likely be positive. Or E, she has polyarticular juvenile idiopathic arthritis. If the ANA, RF, and anti-CCP tests are positive, she will have more aggressive disease. She doesn't have enthesitis-related arthropathy. There's no mention of the Achilles tendon or plantar fascia. You can eliminate psoriatic arthritis, C. There's no mention of any rashes or nail pitting. She does not have systemic JIA, because you guys know how to recognize that. So you're either between B and E. And if the tests are negative, that's the opposite. It won't have a more aggressive disease. It will be the opposite. That's why E is correct answer. All right, these are shorter. 5-year-old girl brought to your office, swollen left wrist. There's warmth, erythema, and decreased range of motion of the wrist, all consistent with the diagnosis of OJIA. In addition to starting a regular anti-inflammatory medication, the next step should be which of the following? A, refer for a daytime splint for the wrist. B, refer to ophthalmology. C, refer to orthopedics for synovial biopsy. D, refer to social work for school modifications. Or E, refer to gastroenterology. And everybody who said B is correct. So if you recall, oligoarticular arthritis, or is the most common, and 70% of those patients present with ANA. And if you remember, ANA is non-specific, but the utility of ANA is risk stratification for uveitis, and that's when you send those kids to ophthalmology. And the last question. The most common bony finding on a skeletal radiograph in JIA is which of the following? A, a normal radiograph. B, periarticular osteopenia. C, joint space narrowing. D, erosions. Or E, periosteal new bone formation. All right, everybody who said A is correct. So I talked about imaging, but it was ultrasound and MRI that would show you the joint space narrowing and the erosions. The skeletal radiograph is not sensitive enough to pick up these changes. However, in the later disease, once the arthritis has progressed, radiograph can pick up the erosions and joint space narrowing. But a normal radiograph is the most common finding. The second would be a periarticular osteopenia. That's when the disease advances. All I have for you is my references, and then any questions that you have.
So Dr. Temez says, it appears that ferritin levels are most helpful of labs in DX-MAS. Is that correct thinking?
I would say yes. If you're looking at the pathophysiology, the ferritin levels, that would be it would be very marked. But I think also ferritin is important, but just looking at the slight changes, monitoring the slight changes in the labs. I think I would also add just looking at the platelets, just because, once hemophagocytosis, sets in, then you're going to have the decrease in those cell lines. So ferritin is very helpful, but I think also looking at the platelets, the white blood cells, and the red blood cells in the context of fever are also important. And at least also to differentiate HLH. I wanted to learn more about, so I hope people took away a lot of the information that I took from this as well.